just makes it look more black. So that's sometimes one way to discern. If it's a GI bleed, it's more loose and kind of thick like tar, versus in iron, they're actually often constipated and dark. Some other special considerations are things like if we're giving a liquid preparation of it, we might dilute it, use a straw so it doesn't stain the teeth, and then rinse the mouth afterwards. Absolutely. Asia says if it's a GI bleed, you know. The smell of a GI bleed is very, very bad, for a not better way to say it. And it's very, once you have some experience with it, you're able to know. So good point, Asia. And then IM injections, we want to use the Z-track method. You guys know what the Z-track method is for giving IM injections?
Yes.
So we pull the sub-Q tissue down, give the injection, pull the needle out, let the skin go back. It seals the medication down into the muscle, because just like iron could stain the mouth, it can also stain the skin. So if we're giving a bunch of iron injections, we'll ultimately start to see these little dots on the skin if we're not using the Z-track method. And they'll stay there. They're not temporary. Let's talk about anticoagulants and antiplatelets. We're kind of talking about all things blood related right now. So anticoagulants are things like heparin, warfarin, enoxaparin, some of our new oral agents as well that are out there. They interfere with the clotting process. Versus things like antiplatelets, they interfere with platelet aggregation. Platelets are sticky. So platelets are circulating around our body all the time. Their job is to go to an area of inflammation or injury, stick to it. They think they're helping, begin to create a platelet plug, part of the clotting cascade. But if it, say, is a plaque formation in the coronary artery, we don't want platelets to go there and stick. That will make the problem worse. So we give antiplatelet aggregates or antiplatelet medications, and it makes platelets sticky. So the platelets are still attracted to that area of inflammation or injury, but they don't stick. They're not going to create worse problems at that plaque buildup. However, of course, if you wanted to stop someone from bleeding, their platelets also aren't going to be able to go there and create a good platelet plug. So they still put them at risk for bleeding. So PO medications, the most typical are aspirin and clopidogrel, which is Plavix. And then we do have an IV medication, which is apixaban. All right, let's talk a little bit more about these two, heparin and warfarin, and compare them. So route, heparin can be given IV or sub-Q versus warfarin, which is given oral. Onset, immediate with IV heparin. Sub-Q takes an hour or two, but still very quick. Warfarin, we don't see an impact in the clotting cascade for 3 to 5 days after administration of warfarin. So a long onset. When we're looking at labs for heparin, we look at the APTT level. And we're looking at warfarin, we look at the INR level. Normal INR level is less than 1. But we want it to be what we call therapeutic, right? So we are looking for that INR level to be between 2 and 3. That's the therapeutic level of the INR. The APTT, normal is like 30 to 40. Therapeutic is 1.5 to 2 times the normal, which would be 45 to 80. Most typically, we check this when we're giving IV heparin. What would it tell you if the APTT or the INR were above therapeutic levels? Tell me in the chat. You're a post-knee patient like we talked about before, and they don't have enough, they stop taking their warfarin, then they're at risk for a clot. And then, of course, the last thing we really have to know about these two is the antidote. So the antidote for heparin is protamine sulfate. And the antidote for Coumadin or warfarin is vitamin K. And we give that to patients when they've had too much and they're at risk for bleeding. We'll give them an antidote to reverse some of that medication. All right. Not as much with heparin. Heparin's usually only in the hospital. Not very typically are patients getting heparin outside of the hospital. Lovenox, which is a low molecular weight heparin, can be given outside of the hospital, but it's tolerated pretty well. Coumadin or warfarin is our biggest thing that we give. That's a very, very potent anticoagulant. It has a black box warning. I mean, it's a very, very high-risk medication. So those patients, yes, we need to be cognizant of things like garlic, ginkgo, and vitamin K foods. With vitamin K-rich foods, which are things like dark leafy green vegetables, really healthy foods, we used to tell patients just to avoid them. Now we say, if you like them and you eat them, keep eating them. Just eat them at a consistent level. Don't spend a whole week eating kale every day and then don't eat kale for 3 weeks. It's going to throw your levels all off. All right, let's do a little bit more here, and then we'll take our next break. So thrombolytics are given to dissolve clots, right? So the opposite of what we were just talking about with anticoagulants, now we're talking about thrombolytics. So these are given when patients typically have PE, pulmonary embolism, stroke, CVA, right? An embolic stroke. Contraindications then are things like internal bleeding, aortic dissection. If they're at risk for bleeding, a brain tumor is an automatic contraindication as well because it's very likely to bleed. So we have to weigh the risk versus benefits. The patient has a clot that we want to dissolve. We're going to give a thrombolytic. It's not just going to go to that particular clot and dissolve it. It's going to cause clot dissolving all over the body, which is going to put them at high risk for bleeding, spontaneous bleeding. Critical time frame when we talk about giving them for a stroke is 4 to 6 hours. Best outcome, though, is if it's given within 2 to 4. Okay, so there's a very tight window. When we talk about embolic stroke patients, we have to know exactly when their symptoms started. If the patient was found with symptoms, we can never give thrombolytics because that could have been 8 hours. We have to know when those symptoms started. We have to know exactly when the time frame starts. Let's work through our GI meds and we'll take that break. So this client is prescribed esomeprazole daily. Which statement to the nurse indicates a desired outcome of the therapy? So this is a prozole medication known to treat GERD, right? So these are acid-reducing medications. So this is another pharm question. We got to think, what is the question asking us? Is it asking us about adverse effects? Is it asking us about contraindications? This is asking us about desired outcome of the therapy. All right, so the correct response here is number 3. It's number 3 because of what it's asking us. Let's talk through each one. So number 1, my bone scan shows no signs of osteoporosis. It is common that these medications can, in fact, cause breakdown of bones. But that's not a desired outcome of therapy, right? That's how pharm questions can be a little tricky. If we don't understand what it's asking us, then we might be like, oh yeah, that's good, right? Number 2, during meals, I seem to choke on liquids. Well, that certainly doesn't seem like a desired outcome of therapy, right? Choking on something. Patients who have GERD can develop esophageal stricture that can cause this thing, but that's not a desired outcome of therapy. And number 4, I'll eat small, frequent meals during the day. Sure, that seems like a great thing for our GERD patients, but again, it's not a desired outcome of therapy. Decreasing bloating and acid production, which are common of GERD, are desired outcomes of therapy. All right, so our upper GI system meds are covered on page 47 to 48 and really cover not only our PPIs, which is what we were just talking about, as meprazole is a PPI, a proton pump inhibitor. We also have things like antacids, histamine 2 antagonists, which are things like ranitidine, okay, Zantac, Pepcid, mucosal protectants. Sulcrophate is the most common. It's given 1 hour before meals, and it coats or protects the stomach. Then things like antiemetics are also upper GI related, right, to decrease nausea and vomiting. Phenergan, Reglan, okay, Zofran. And the teaching that goes along with that, using over-the-counter meds beyond their time frame, they really should only be used for a couple of weeks unless you're under the direction of a provider. Dietary changes, low acid, low gas producing foods, eating those small frequent meals will be most helpful to these patients. Antacids are taken 60 minutes after PO iron. So we just said a couple slides ago when we were talking about iron that antacids can decrease absorption. So we don't take them at least till 60 minutes after or 2 hours before. Okay. And lastly, our lower GI system medications are things like antidiarrheals, stool softeners, laxatives. So antidiarrheals might be things like Lamodal or Imodium. Things like stool softeners, right? Docusate sodium or Colace is our most typical. Doesn't cause diarrhea, remember, it just makes the stool soft. Laxatives, on the other end, actually stimulate and promote GI motility, and those patients can actually become dependent on those. So those shouldn't be used on a regular basis. And then monitoring fluid and electrolytes, because if a patient's having diarrhea or we give medications and end up with diarrhea, then especially our older adult patients are highly at risk for fluid and electrolyte issues. All right, guys, that was a lot in an hour. I know. What's next, okay? So a nurse prepares to administer furosemide to a client. Which findings should be reported? All right, so let's just think in our heads. All right, get our heads back in there. We are talking about furosemide. Furosemide is what kind of medication? Diuretic, yeah. So it's Lasix, yes, exactly right. So think in your heads about what might be some things to report. I'm going to put the answers out. See what you guys think. right. So the answer here is hypokalemia. So Lasix, furosemide, is a potassium wasting, right, diuretic. So we lose potassium when we lose the urine output that we expect. So polyuria is expected, right? Increased urine output would almost be expected. Now, hypertension and hypoglycemia certainly might be things that you would report, but this is really what would you expect to report or expect as an adverse effect related to furosemide. Good. All right. Let's move on and talk a little bit more about diuretics. So, common side effects of non-potassium sparing diuretics, right, or potassium wasting diuretics: hypokalemia, hyponatremia, and hyperglycemia. Okay, so the potassium and the sodium move together, and the sugar moves the other way. Okay, so we hold on to that. We actually get hyperglycemia. Versus our potassium wasting diuretics, or I'm sorry, our potassium sparing diuretics are the opposite, right? We hold on to the potassium in the sodium. So we get hyperkalemia, hypernatremia. So two potassium sparing diuretics are spironolactone, which we already talked about. That's the most common one. And then risks for anybody who's taking diuretic certainly is safety. We're thinking about falls. We're thinking about orthostatic hypotension, fluid and electrolyte imbalances that could cause them to be confused, or instability, right? So safety, safety, safety when we're talking about giving diuretics. Anticholinergics is another class of medications. So someone just asked a question about potassium sparing, so I'm just going to go back to that for one quick second and try to clear that up. Potassium sparing diuretics, meaning that we spare it, we hold on to it. Spironolactone is the most common, versus furosemide, which is a potassium wasting or a potassium losing diuretic. So when we give those, we expect the potassium levels to go down. The potassium will be lost in the urine. So we often will give potassium supplementation to people who are on Lasix or furosemide long term. Versus potassium sparing, they hold on to their potassium, which is good because we don't have to supplement with potassium, but then we also have to still monitor their potassium levels because they could have elevated potassium levels. Okay? All right, anticholinergics. So anticholinergics are muscarinic antagonists, we also call them, are medications that we give for many different reasons, but we get this same commonality of symptoms: dry eyes, mouth and skin, constipation, urinary retention, and memory impairment or confusion. No see, no pee, no stool, no drool. No see, no pee, no stool, no drool. It's just a funny way to kind of remember it. So if you can remember the side effects of these medications, we then have to think about nursing interventions, okay? They often need eye drops. Their eyes are so dry. Sugar-free candies to suck on for dry mouth. Ice chips. Constipation are classic constipation interventions, right? More fluids, more walking, more fiber. Urinary retention actually may be one of the main reasons we have to discontinue this medication, because there's not a whole lot we can do about urinary retention unless they're hospitalized. Then, of course, they can have a catheter, but that's a whole nother risk factors, right? All right, let's move on to our immune system medications. Client has a prescription for metronidazole. Which statement indicates a need for teaching to be reinforced? So think about what this is asking us. This is an azole medication. Which statement indicates a need for teaching to be reinforced? So again, this is a false stem medication, or false stem question. That's asking us then to identify what is incorrect. Ellen, that's 51 to 53. Sorry about that. So which statement indicates a need for teaching to be reinforced? So the correct response here is only 1 glass of wine may be consumed each day. It's a huge contraindication between alcohol and metronidazole, also known as Flagyl. It can cause a disulfurium reaction, which is a very serious reaction. So no alcohol whatsoever. I know that always we tell patients when they go on antibiotics that you can't consume alcohol. It decreases effectiveness. But in this case, it doesn't just decrease effectiveness. It truly will cause them to have a severe reaction, even 1 glass. So we have to really be clear on that. Yes, their urine may get a little bit more dark while taking this. They may get a metabolic or metallic taste, and they may need an alteration in their dose of warfarin. Those are all correct statements. All right, some further discussion of antimicrobials. How does the doctor or provider know which antibiotic to give? What's the best way for them to find that out? Anybody know? A culture tells us what kind of bacteria it is. A sensitivity tells us what type of antibiotic or antimicrobial the organism is sensitive to. So it's a 2-part thing. A culture tells us what organism it is. Sensitivity tells us which medication will kill this organism. There are 2 antibiotics that are nephrotoxic, gentamicin and vancomycin. They're nephrotoxic and they are ototoxic. Those are highly tested adverse effects of these medications. So know those for sure. Gentamicin, vancomycin, nephro and ototoxic. So it's the acoustic or the 8th cranial nerve that can be affected because that's the cranial nerve that affects hearing. I don't think as LPNs it's really important that you know it's the 8th cranial nerve, but I think it's important you know they're nephrotoxic and ototoxic. Okay? How do we determine, or what is the best way for us to determine levels of antibiotics in the blood? What do we draw? What do we call that? Peaks and troughs. So we determine a peak 30 minutes after the dose is given. That tells us the max amount of antibiotic or antimicrobial in the system. A trough then is drawn right before the next dose. That tells us the lowest amount of that medication in the system. That helps us to prevent things like nephrotoxicity or ototoxicity in those medications. Next, we're going to move into musculoskeletal medications and talk about 4 different classes of medications on this little chart here. Methotrexate, steroids, NSAIDs, and anti-gouts. So I want you to spend a couple minutes looking at this and mentally kind of put a little note next to which one of these medications would it be important for us to monitor infection. And it can be one or all of them. Which medications do we need to avoid purines? Monitor bleeding, Okay, so just take a minute and glance it over. All right, let's go through it. Which pages? 53 to 54 for these pages. All right, so methotrexate and steroids are both immunosuppressants. We already talked about methotrexate earlier about rheumatoid arthritis, right? We talked about how it suppresses the immune system, which is why it's used to treat the autoimmune disorder, but it's also a chemotherapy medication. So it's going to suppress blood cell formation. So it suppresses red blood cell, white blood cell, and platelet formation. Steroids do the same, just they're also going to suppress the immune system, which is how they decrease inflammation. Avoid purines are giving for gout. So gout medications, or gout in general, is related to uric acid formation. So we avoid a high purine diet, okay, with that patient. Purines are found in organ meat, okay, and alcoholic beverages, most typical. Then we have monitor bleeding. So the patients that we, just trying to mute that noise. All right, so monitor bleeding, methotrexate, we already talked about, suppresses platelet formation. Okay, so that's why, and NSAIDs also put the patient at risk. So we're going to monitor bleeding in those patients. And then in our patients who are on steroids long term, we want to think about decreasing their risk for osteoporosis. So increasing exercise, calcium, and vitamin D are all going to be helpful in decreasing their risk for osteoporosis. Up next, we have nervous system medications. So you can see that this really just marches through the book. And now we're on pages 54 to 59, which is designed that way. And we're going to talk about medications that affect the nervous system, also some psychiatric medications here. I know we're going to talk about mental health on the last day. We're going to talk about some medications that affect mental health now. So a nurse reinforces teaching to a client regarding side effects. Which statement indicates teaching is effective? So again, it's a farm, so we really have to be paying attention to what is it asking us. Side effects, contraindications. Which statement indicates teaching is effective? Okay. All right, let's see what we think here. So this medication is an SSRI, okay, which is a medication that can be used to treat depression. And something we have to think really a lot about with our SSRIs is serotonin syndrome, okay? So serotonin syndrome can occur when we give SSRIs related to how they work. And excessive sweating is a symptom of serotonin syndrome. Also things like mental status changes, hallucinations, agitation, tachycardia, dizziness, tremors, seizures. They can be really, really severe symptoms, but excessive sweating is something that happens pretty early on, and sometimes patients can overlook it. So we need to make sure that that happens, that they report that immediately, okay? So number one, the medication may cause panic attacks during the first week. That's an adverse response. So we don't want them to just say, oh yeah, that might happen, that's okay. So that's not an appropriate statement. Number three, they should not drink alcohol while taking SSRIs. And then with number four, symptoms resolve slowly. Initial response 1 to 3 weeks. However, a few months is too long. So we really think they should start to see some benefit before a few months. All right, let's look at this chart and do a little bit more comparison of some of our antidepressants. So just think for a minute and try to line these up. Like, which one of these has anticholinergic side effects? Avoid alcohol. Just give it a minute, see what you think. We'll go through it. We just talked about what anticholinergic side effects are, right? No C, no pee, no stool, no drool. So dry eyes, dry mouth, constipation. Avoiding alcohol, really, with any of our antidepressants, because really people who have depression should avoid alcohol, right? So there's a double kind of thing there. Depression plus antidepressants, those patients should avoid alcohol. Avoiding tyramine. So MAOIs are medications that are used to treat depression. They shouldn't have tyramine. Tyramine is found in tired or old protein, smoked foods, okay? Sausage, cured meats, aged cheeses, and yeast. Fatigue and drowsiness are common with SSRIs and tricyclics, especially in the beginning. They might get better, but they should be taken at bedtime at first to see how they feel. And then our SSRIs, because of serotonin syndrome that we just talked about, are most what we need to monitor for agitation, confusion, and hallucinations, because that's specific to serotonin syndrome.